Good morning. Today we'll be talking about the topic anchorage. What do you mean by anchorage? Anchorage means the site of delivery from which a force is exerted. We all know tooth movement during orthodontic therapy is brought by forces generated by active components. The force used to move teeth is derived from the anatomic areas, which act as anchors. We can classify anchorage according to the manner of force application, that is, simple anchorage, stationary anchorage, reciprocal anchorage. According to the jaws involved, we can divide into intramaxillary anchorage, intermaxillary anchorage. According to the site of anchorage, we can classify into intraoral and extraoral and muscular. Extraoral includes cervical, occipital, cranial, facial. According to the number of anchorage units, we can classify anchorage into single or primary anchorage, compound anchorage, or multiple or reinforced anchorage. What do you mean by stationary anchorage? Anchorage in which the manner and application of force tends to displace the anchorage unit bodily in the plane of space in which the force is being applied. Simple anchorage means dental anchorage in which the manner and the application of force tends to change the axial inclination of the tooth or the teeth. Reciprocal anchorage, the resistance offered by two milepost units when the dissipation of equal and opposite forces tends to move each unit towards a normal occlusion. Example, arch expansion using a coffin spring crossed by elastics for the correction of single tooth posterior crossbite. Intraoral anchorage. Anchorage in which all the resistance units are stated within the oral cavity. Various anatomical units, which are teeth, palate, and lingual alveolar bone of the mandible. Extraoral anchorage. Anchorage in which the resistance units are situated outside the oral cavity. Examples are occiput, back of the neck, cranium, and face. Muscular anchorage. The perioral musculature is employed as the resistance units. The muscular anchorage makes use of forces generated by muscles to aid in the movement of teeth. Example, lip bumper to dislodge molars. Intramaxillary anchorage. What do you mean by intramaxillary anchorage? When all the units offering the resistance are situated within the same jaw. Intermaxillary anchorage, otherwise known as Baker's anchorage. Anchorage in which the resistance units situated in one jaw are used to effect tooth movement in the opposing jaw. We have type 2, that is class 2 elastic traction applied between the lower molar and upper anteriors, as well as class 3 elastic traction applied between the upper molar and the lower anteriors. We have Baker's anchorage A, class 2 intermaxillary anchorage, and B, the class 3 intermaxillary anchorage, as you see in the pictures. Single or primary anchorage, the resistance provided by a single tooth with greater alveolar support is used to move another tooth with lesser support. Compound anchorage. The resistance provided by the more than one tooth with greater support is used to move teeth with the lesser support. What do you mean by reinforced or multiple anchorage? Augmentation of anchorage by various means such as external forces, that is, cranium, back of the neck, and the face. Use of transpalatal arch and lingual arches. Transpalatal arch spans the palate in a transverse direction, connecting the first permanent molars of either side. Lingual arch connects the contralateral lower molars running along the lingual aspect of the mandibular arch, prevents mesial movement of the lower molars. We have upper anterior inclined plane, that is a removal appliance, which includes An upper anterior inclined plane results in the forward glide of the mandible during closure of the jaw. We have upper anterior inclined plane or we have a sweat appliance. Coming on to the sources of anchorage. We have intraoral, that is the teeth. So the anchorage potential of teeth depends on number of factors such as root surface area, root form. Root surface area plays an important role as teeth with larger root surface area offers greater anchorage. Root form, we have three types: round, flat, triangular. Round roots resist horizontal directed forces in any direction. Flat roots resist movements in the mesiodistal direction. Triangular roots offers the maximum resistance to displacement. You can see the incisor has a round or a triangular roots. Mandibular roots mandibular molars have a root surface area which is increased and also number of roots are more. So these are the positions of our anchorage units. A, that is the teeth. B is the alveolar bone. C is the basal jaw. D is the musculature. E is the occipital region of the cranium. F is the parietal region of the cranium. G is the back of the neck. H is the mandibular symphysis. Coming on to the size and the number of roots. Multi-rooted teeth with larger roots have greater ability to withstand stress. The longer the root, the deeper is it embedded in the bone and the greater is its resistance to the displacement. Example, single-rooted is the canine, which has a longer root, and multi-rooted are our molars. Alveolar bone surrounds a tooth, offers resistance to tooth movement up to a certain amount of force. When the force applied exceeds a certain limit, the alveolar bone permits tooth movement, bone remodeling. Musculature. Abnormal hypertonic musculature causes flaring and spacing of teeth, while hypertonic muscles exert restrictive forces in a lingual direction. Dental anchorage may be increased by making use of hypertonic labial musculature in case of a lip bump. Basal bone. Intraoral sources of anchorage include the hard palate and the lingual surface of the mandible, which can be used to augment intramaxillary or intermaxillary anchorage. The mucosa and underlying bone used as an anchorage when using Nance buttons. Extraorally, we have cranium, back of the neck, facial bones. Cranium includes occipital or parietal anchorage, obtained using headgears that derived anchorage from the occipital or parietal region. These devices are used along with the face bone to restrict maxillary growth or move the dentition or maxillary bone distally. Back of the neck, that is also called the cervical anchorage. This is obtained from the neck or cervical region. This type of headgear is called cervical headgear. Facial bone. The frontal and the mandibular symphysis offer anchorage during face mask therapy in order to protract the maxilla. These are called headgears. How can we augment anchorage? We can augment anchorage by 1, maximizing the root surface area. 2, using a bodily movement or using a tipping movement. 3, including second molar sin treatment. 4, using occlusal forces and the growth pattern. 5, selection of teeth for extraction. 6, the use of extraoral anchorage. 7, use of transpalatal and lingual arches. 8, separating canine retraction. 9, use of temporary anchorage devices. Now coming on to the topic, anchorage planning. Prior to the initiation of the orthodontic therapy, it is essential to carefully assess the anchorage demands. The number and the anchorage required depends upon the number of teeth being moved, type of teeth being moved, type of tooth movement, duration of the tooth movement, skeletal pattern, and occlusal interlock. The anchorage needs to be planned in all the three planes of space, that is, sagittal, transverse, and vertical. Coming on to the classification of dental anchorage. Based on the extent of anterior retraction versus anchor molars moving forward, we have minimum anchorage, moderate anchorage, maximum anchorage, and absolute anchorage. Minimum anchorage means more than half of the extraction space can be lost by the anchor teeth moving mesially. That means 50% of the space will be closed by the anchor unit. Moderate anchorage, the anchor teeth can be permitted to move forward into one-fourth to half the extraction space. Maximum anchorage, that means not more than one-fourth of the extraction space, should be lost by forward movement of the anchor teeth. Absolute anchorage means the entire extraction space is used for the retraction of the anteriors. There is no forward movement of anchor teeth as temporary anchorage devices are used. Coming on to the last topic, loss of anchorage. The unplanned and unexpected movement of the anchor teeth during orthodontic therapy. Some of the causes are of loss of anchorage are poor appliance design, poor appliance adjustment, and poor patient behavior. Thank you.
Okay.